Thanks so much, Tonya. Thank you so much, Tonya. Hi, everyone. We're just going to wait a couple of minutes for people to join and then we'll get going. Thank you. Thank you. Hi, everyone who's joined. We are just going to wait another minute and then we'll get going. Thank you. Thank you. Hi, everyone. So it's a couple of minutes past 11. So we are going to formally start today's webinar. For those that don't know me, hello, I'm Beth, and I'm the Chief Exec of Women and Children First. We are here, as you know, to celebrate the work of Women and Children First as we close after 25 years. So a massive welcome. Thank you to you all who's joined to hear about the work of Women and Children First and our partners, and a massive thanks to all of the presenters and panelists who are joining today to share their expertise and experience with us. So it wouldn't be a webinar without a housekeeping section. So here are a few things that I just need to flag with you all at the outset. First of all, this webinar is being recorded so that those who can't join today can watch back at a later date. If anyone's uncomfortable with that, I can assure you that you've all been brought in, your cameras off and muted, and you can remove your names from your profile so they're not visible. You just have to right click on your name and then click rename. Just put your initials there if that's what you're more comfortable doing. But can I remind presenters and panelists to keep your names visible so everyone knows who they're listening to, and do stay muted until it's your time to speak. In terms of timings, we're planning that the webinar will be about 90 minutes. And in terms of the agenda, for about the first hour, we're going to have a series of presentations and videos. Before that, we're going to have a quick overview about PLA and its history. And then we're going to have a panel discussion for around 30 minutes. If you want to submit any questions to be covered by the panelists, please use the Q&A function. The chat function is disabled for this webinar. And we will endeavour to get to as many questions as we can today, and we'll also try and provide follow-up to people if we can't answer your question today. That's everything from me. So I now have the pleasure of handing over to Women and Children First's founder, Anthony Costello. Anthony has kindly agreed to chair today's webinar, and he's going to begin by giving us an overview of PLA and its history. So Anthony, over to you. Thank you.
Thanks very much, Beth. That's great. And today is a celebration. It's a celebration of 25 years of incredible work from Women and Children First, and especially from all the partners. And you're going to see that there is a fantastic legacy here and the future is assured because there are so many partners who have built their own programs and developed the whole concept of PLA. And so I want to kick off by just starting a little bit about the history of why we set up Women and Children First, and a little bit about this so-called PLA, Participatory Learning and Action, which has become a key part. So if you can put up the slides, Tonya. Great, and I hope I've got control somewhere. Yeah, you have. So, Women and Children First set off with the idea of improving care, particularly for women and children, especially in very remote, poor areas. And as a background, in the 1990s, we'd set up a very big, there was a lot more interest in newborn care because it was more than half of all child mortality and not much was being done. We had a big conference in Kathmandu in 1997, and that led on to a book that was a digest of all the presentations at that conference. And in the 90s, we had done with Alison Bolam and Dharma Manandar and others a randomized controlled trial of health education for postnatal mums in Kathmandu, both in the hospital and followed up at home. And to our surprise, the trial, we had a control group of mothers, didn't actually show any real difference on things like diarrhea, pneumonia, and family planning and the like. We were very disappointed by this. And then we heard about a program in Bolivia, the Warmi Project, which had set up a program through Save the Children Fund in Bolivia, getting groups of women in remote mountainous areas together to talk about their problems. And I contacted the designer of this, a fantastic psychologist called Lisa Howard Grabman, and she explained what they were doing and how excited she was by it, but they hadn't done a formal evaluation. And we were just getting into the time. Oh, well, she explained to me the principles of it, which is a community action cycle, where you have a number of meetings of the groups to sort of identify, prioritize their problems, and then move on to, whoops. Oh, is that not working? Yeah, to plan their strategies. Then phase 3 is put them into practice. These were all a series of meetings. And then the group together evaluate what they've done. So the whole thing takes about 18 months or even longer. And you can obviously keep repeating the cycle. So we said, well, let's do this in a more remote district, not in the capital, in a place called Makwanpur. We gave local people cameras and we could see that they were subsistence agriculture. 90% of people at that time of mothers were delivering at home. And the health system was largely dictated to by shamans who would do things like sacrifice chickens and bang a drum and go into trances and the like. And so we set up to do, because it was the new fashion, a cluster randomized trial. So the blue areas were the control areas, the red were intervention. And it's good because Nepal is designed for cluster randomized trials because those boundaries are all kind of 20,000-foot mountains or raging rivers. So you can't get much contamination between the control areas and the intervention areas. But at the same time as we set this up, we were thinking this is such an interesting area. We need a kind of implementation group, not just a bunch of university academics. And so we decided to set up as a group of us got together to set up Women and Children First, with the idea of focusing on initially, groups to target maternal and newborn care, but it's obviously moved on to lots of other things, to radio programs, to various other countries that we've worked in, and I'll come on to that a little bit. So what surprised us was we did this for the first 2.5 years, and we discovered that actually I was very skeptical. I didn't think this was work, getting groups together and run by local women, not by health workers. And when we analysed it, we showed that in the intervention areas, there was a 30% reduction in neonatal mortality, which was incredibly impressive. But in the meantime, we'd set up, and we're going to hear about this in a moment from Nirmala Nair, who has led the Ekjut program for many years now previously with her husband Prasanta. And they also showed in an even bigger and better trial a 32% reduction in NMR. And at the same time, we'd worked on working with groups in Bangladesh, which were extremely lively. And we were very disappointed initially to find no impact. And it took us a while to realize that we got the dose of women's groups wrong, because Bangladesh is very overpopulated or very densely populated. And we actually, after having no impact, we repeated the entire trial with a higher coverage of women's groups and showed an even bigger impact than we'd found in Nepal and India, around 38%. And Kudus will talk to us about it. So overall, we reported about 10 years ago on 7 cluster randomized trials. Not all of them worked because, for example, the one in Mumbai started with much lower mortality rates. But the punchline was that if you could get about 30% or more of locally pregnant women into groups, you could have a really sizable impact on local mortality rates, even in really remote areas with lack of access to healthcare and the like. So this was really exciting, and our reports results were published in the Lancet. And the next trick was to see, could we assess it at scale? And the woman at the bottom here, it was the Secretary of Health for Orissa State. She heard about this and she said, I'm going to scale it up. And she actually set up 140,000 women's groups across Orissa. That's got a population of 50 million. And they evaluated it and they thought it was very successful. And they did it with their own local budgets. And there was another scale-up program we may hear about from Nirmala about in Jharkhand, another state in India. And actually, India, it's really taken off, this whole approach. So we've learned a lot about how women's groups actually work. It's more complicated than you think. Women bring a shared memory to their groups. They build solidarity. Their stress levels are reduced because they're not alone. They share resources. If one family is becoming stressed through a funeral or a wedding or something, there's consumption smoothing, the economists talk about, where people share resources. They agitate for new things. It's a holistic approach, and surprising things happen. And sorry, just going back, WHO analyzed all of this research independently, and they came up with their own recommendation for policy around the world for this to be introduced. So that was really encouraging. If you want to know more about this, well, in the meantime, we've had a whole succession of fantastic chairs who have done so much. Imogen, Hazel, Carol, and now Rachel. Great executive directors like Dorothy, Ros Davis, Mikey, Rosato, and now Beth. And if you want to look at a whole load of videos, we're going to show you some in a minute, but there are on the website. And whoops. And also we've got some fantastic staff who are moving on, but I hope this isn't the end. And I have a feeling that aspects of this will be resurrected at some stage. A big question is, did participation empower women? And I raise that because in the kind of development and anthropological literature, there's been a kind of debate going on. I believe that women's group conversations are very important and did improve health and survival. And we've demonstrated that repeatedly if you get the conditions right and you get the coverage right. Pressing the wrong button. Did it change their lives more fundamentally? That's a more difficult thing. But one example is in Nepal. I went back there in 2015 just after the earthquake, and Naomi will remember this well and may talk about this later. And we went to Makwanpur, where we had stopped funding like 7 or 8 years earlier. And we discovered that about 3/4 of the groups that had been set up were still running and were very active in helping with the rehabilitation and recovery from a really bad earthquake. But at the same time, there are issues. People have suggested that there was one paper that was famous saying, is it a panacea or is it a placebo? And of course, it's not going to change the fundamental elements of poverty, particularly, or of oppression or of climate change. But these are, elements but it can make an important contribution in my view. But we can talk about that maybe a little bit later. Whoops. Oh, have I gone up? I may have lost it. Hang on, there we go. Oh, thank you. It was the last slide anyway. I mean, I actually, for my sins, I'm not selling a book because it's, but just to say there are a lot of issues that this touches upon that involving women in groups. If you could go to the last slide, Tonya, I don't know if you can do that. Uh, yeah, that one. We need to think. In Bangladesh, there's been some fantastic work with women and men's groups that we may talk about on diabetes, which is a huge problem. There are big issues around child development and adolescent health that I think Nirmala is going to talk about. There is a great potential for this to help with climate change and resilience. Remember, women and children are going to be the biggest victims of climate change. And many countries are already facing very big problems with agriculture, with floods, with droughts, with environmental challenges, with water supply, etc., etc. And bringing people together to try and solve their own problems is going to be a very key element of that. And not just in the poorest countries. The climate change issues are affecting everywhere in the world, every country and every region. And this is going to grow in importance. And women and children and disabled people and the like are going to be, in the center of facing that maelstrom. So we're going to talk about some of those, and there are lots of other things. I personally think in Britain and Europe and America, loneliness is one of the biggest challenges, and a lot of long-term conditions or prisoner rehabilitation or issues of corruption. We better not get onto that. And the whole culture of our sort of financialized economic world. But anyway, I'm going to stop there. I'm a bit early. That's great. And I'm going to introduce the first of our speakers. And the first person is Nirmala Nair, who's been a fantastic colleague and friend for the last 25 years. And she's going to talk about, they've done a whole range of big studies and they've grown from quite a small organization to one of the biggest rural non-government organizations in India. And so I'm going to hand the floor to her, and she's going to talk a bit about PLA scale up and some other things, I think, including their work with adolescents. But anyway, over to you, Nirmala.
Thank you, Anthony. And I wouldn't say we are the largest organization, but yeah, we have made some strides in that area. So we are quite big now with more than 1,100 people working in Ekjut. So it's a large number. Tanya, can I have the slides, please? So I think Anthony has already mentioned many of the things that I was planning to do. And like he said, we started, Bolivia actually started this whole thing. And I think it was 1980 and not later on, because the paper that I have gives the date as 1980, which means it was almost 25 years before we, Ekjut started this work in Jharkhand. And Anthony, you will recall this meeting. This was the first community meeting that we had way back in 2005, where the person you're talking to is now happens to be one of our board members, Tamali. So you'll be happy to know that. 20 years later, again in 2025, this is a very recent picture which was taken just last week. And you can see some of the women in white and green borders. They are the Ashas under the National Health Mission who are actually conducting these meetings. Even now, this is happening, and this is by the Ashas and the National Health Mission, where they are looking at nutrition as one of the indicators for improvement. Next slide, please. So the problem we already know. So when we started this work, scale up in Jharkhand, the MMR was already quite low, whereas the NMR was still high. And if you have to look at NMR per se, it has come down in Jharkhand, but there is still a scope for improvement. This is the context that we work in is largely rural, underserved, and majority of the communities that we work with are vulnerable and indigenous populations. As you know, India has almost a 8% population who are tribal in nature. And this again, picture on the left side is very recent, again taken last week. So high levels of undernutrition among children, mothers, adolescents led us to talk about these issues through the PLA approach. And we also there are high migration to cities also because of the poverty, like Anthony mentioned. So many of the women in the communities may be just single-headed woman-headed households, which also brings into play the empowerment issues that we need to talk about, like Anthony was just now mentioning. Next slide, please. So I'm not going through this because Anthony has just now spoken about this. But the woman on the left is the woman on the left, as I said, is the ASHA worker. ASHA is actually an acronym for accredited social health activists, which fall under the NHM, and they are placed in every village in the country, who are kind of a connect between the community and the health system. And they are the ones who are right now conducting these meetings in the community. Next slide, please. So Anthony already spoke about the first trial that was done way back in 2005 and 8, and we found a 32% reduction in newborn mortality. But overall, that was the overall reduction. But if you looked at the last 2 years of intervention, it was almost 45%, which was actually remarkable in the sense this got published in the Lancet, and it got the PLA actually got a hype after that. More interestingly, 71% of the most marginalized communities benefited from that particular trial. And as I mentioned earlier, our communities are we're mostly tribal people. So we define marginalized as those belonging to either scheduled caste or scheduled tribe. India has a lot of caste systems, so we included all people with low wealth quintiles also into this, and those with poor literacy levels. So these are the 3 criteria that define the marginalized people. And we also found maternal deaths in the intervention much less than in the control areas. And this was largely done by facilitators chosen by Ekjut. That is a time when the big lottery fund came in, and soon after the first trial, and that was a time when we started collaborating with WCF, and UCL has always been our partner right from the beginning. So we did this particular trial called Jharkhand and Orissa Health Action Research, which is in short Johar trial, where that was done with the ASHAs or the frontline health workers, and that is and we again found a 31% reduction in newborn mortality, and a 61% reduction in among the most marginalized people. Even the maternal deaths were relatively less in the intervention areas. So this was while the first trial was 3 years, the second trial was only for 2 years, and we found the similar results. So then that prompted us to do the scale up in a larger area, which is entire Jharkhand state, which had 24 districts and close to 19.4 million population. And we again found this was a 2-year. I think the years are mentioned wrong. It was between 2017 and 19, 2 years, 2.5 years of intervention. Actually, 2 years full of intervention, and we found a 24% reduction in overall newborn mortality. And again, the most marginalized benefited the most. So this was done in 32,000 villages and hamlets. India has a lot of hamlets that get covered, and for more than 40,000 frontline health workers or the ASHAs conducted these meetings, and more than 700,000 PLA meetings were conducted in this entire trial. Next, please. Yeah. So these are some of the learnings from our large scale up. So state machinery was mobilized right from the beginning, starting from the village to the state level. All health cadres were involved in the planning, the implementation, and monthly review meetings that helped them to follow up on the how the implementation was going. The cost of training reduced by 95% because we used a very creative, innovative, on-the-job training methodology, which I don't have time right now to discuss that. But if anybody is interested, I would definitely share the document with you. Then district level coordinators helped with the catch-up monthly training to resolve local issues that came up as and when they could, as and when they met every month. One thing that actually helped with the successful adaptation was timely payment of incentives to the frontline health workers. So each ASHA was paid close to 100 rupees, which amounts to, I'm not sure how much in dollars, maybe 0.1 pound or something. And each meeting had very creative new activities, like content was different, picture cards were used, methods, and the design was contextualized in these meetings. We had another innovation, that was the GIS and MIS mapping that helped the which was actually, by the end of the trial, this was handed over to the government, and they could then track all these meetings that were happening in the remote areas. So they had access to the dashboard, and they would be able to follow on any ASHA particularly, or the village, or the block, whichever they wanted to look at. Next, please. So these are some of the things that we already have done and tried and done. Some of them are researches, some are before and after studies. But we have tried with PLA alone. We've tried with PLA and home visits, where we had nutrition as one of our main indicators to improve, sorry. And PLA with home visit and creches was also done as a research study. Then PLA with leadership and livelihood was something that we did with adolescent groups, because leadership and livelihood activities got the adolescents together to have the meeting, which enabled the meetings to happen more effectively. Then another study that was done with video dissemination alongside PLA, and the results were quite good. Currently, what we are doing is PLA home visits and system strengthening, which is on nutrition, improving nutrition among mothers and children. Next, please. Yeah. So these are the different areas that we have used for PLA, newborn mortality and maternal mortality reduction, as I already mentioned. Undernutrition was something that we already spoke about. Early childhood development in care was also something that we have tried, and although it is not a research study, it had to be stalled, but that was something that we would still be interested in doing. And with adolescents, like I said, health, nutrition, and well-being. We also used PLA for gender-based to reduce gender-based violence in the community. The paper is also published on that. And right now, for the last 5 years, we've been trying PLA for psychosocial disabilities or mental health, and also non-communicable diseases. During the COVID, we used it for just a 4-meeting cycle to address vaccine hesitancy also. Next, please. And this is the scale of our work. If you call it the vertical scale up, we have moved to many states in the country: Jharkhand, Bihar, Orissa, Rajasthan, Uttarakhand, and currently we are doing in Uttarakhand as well as in Meghalaya. Geographical scale up, again, 83 districts have been covered in the country, more than 100,000 villages, and touching the lives of more than 60 million women in the country. We have partnership with more than 50 non-governmental organizations, and the meetings are happening in more than 1 million villages in the country. Next, please. Next is, I think, a video. If there is time, and Anthony, can we show that, or maybe later?
No, go ahead. I think we can do that.
Yeah. So maybe
In 2005, Ekjut began using a powerful community engagement process called PLA, Participatory Learning and Action. Their focus was to improve maternal and newborn health. 40,000 Ashas were innovatively trained to be PLA facilitators. Spread across 3 years led to newborn deaths falling by a quarter, including among the poorest. An estimated 10,000 newborn lives saved. The evaluation study shows that PLA is effective in improving newborn survival at scale.
thank you, Tanya.
Hang on, am I muted? No, could you hear me? Nirmala, that was
Yeah, I can hear you.
absolutely fantastic. And I'm going to bring you back in perhaps to the panel discussion, if you can hang on, to talk a bit more about Scale Up, because this is an amazing program, and doing the research study and then the local scale up with government workers and then going to scale across a big state is unbelievable. And you do get some attenuation of the effect, but you're still getting 26% impact on mortality over 2 years in the most poorest group. So I think this is fantastic work. But I'm going to move on because we're trying to compress a lot. I'm going to move to Malawi, because we formed a relationship with two fantastic pediatricians, Peter Kazembe, who sadly died a few years ago, and Charles Mansamba. And we set up a thing called Maimwana, and also a thing called Maikanda. So Maimwana was mother and newborn, and we set up a trial in one district. Maikanda was stands for mother and child, and that was in 3 other districts. And so there's been a lot of work going on there in Malawi, and there's going to be a little video now. Eric, the director of Maikanda, has sent us a 5-minute video. So let's show that straight away now, if you can, Tonya.
Nene chidachitika mai amene anali oyembekezera mai Jameson ndetamba mimba kuwawa adambotaya magazi sanathamangire opita ku chipatala, anangokhala konkuno kumudzi amati achitira konkuno. Ndena ngasiti dazolowera kuti timachitira kuno kumudzi mpaka na nthawi imafika yoti tiganizire kuti mwina timutenge munthu tipite naye ku chipatala, nkupezeka zoti nthawi yatha mimba ija nkuleka opweteka, basi munthu uja mpano omwalira.
It all starts in the community. The communities hold the key, not just the hospital. By the time they come to a hospital, it's already too late. So we need to look at ways in which we can empower the community to be able to identify the problems early and come up with the solutions early. Maimwana is all about sustainable community interventions that we feel may make a difference. We're looking at women's groups where women sit together, discuss issues together, identify the problems, and come up with the solutions themselves. Once they identify the problem themselves, they see it as their problem, and they will solve it the way they see fit to solve that problem.
Ife apa mavuto athu tinapeza ovutikitsitsa tinaona chimene chalipoyambirira nkusowa kwa magazi, kuchepa kwa magazi, kenaka kuzizidwa ngati malungo, kenaka tinapeza mavuto ake ngati mayendedwe, kusowa kwa mayendedwe. Kwa njira zake tinaganiza ngati kuchepa kwa magazi, tinaganiza kulima kudimba ndikuweta nkhumba. Pa mayendedwe amaimwana atithandizapo njinga, ndiye kuchepesa malungo panopa anatipasaso maneti amene tikugawira wanthu. Moyo wa amayi ni ana nitsadimba zikugwirizana apa kuti kudimba timadzalako ndiyo za masamba ni zinthu zambiri zogwiritsa ntchito kuti ngati tomato kuti mwana azipezako magazi akamadya wowisi ngati masaladi azipezako magazi ni ndiyo za masamba kuti azibwezeresako chani magazi mthupi.
Mutu umodzi susenza denga. One head cannot lift a whole roof. If you are alone in your house, you're confronted with a medical problem, you cannot solve it alone. So in the women's groups, we bring several women together. They share ideas and plan together. So by so doing, they are sharing the burden in the community and they're able to carry it together and solve it together.
Hello, my name is Eric Setikani. I am the Executive Director for Maikanda Trust. Participatory Learning Action groups have been implemented in Malawi since 2005 by local organizations, Maimwana and Maikanda Trust, in partnership with the Women Children First, which is UK-based. Two of the randomized controlled trials that proved participatory learning action effectiveness in reducing maternal and newborn mortality took place here in Malawi. The approach is very powerful. Some groups continue to meet years after the projects have stopped. With its long and successful history in Malawi, we believe groups could be delivered at a large scale and managed through the country's community health system. We reached out to the Minister of Health with that idea, and they are supportive to run a district-wide pilot test of the methodology, assessing how well it can be delivered through that system. This is an exciting opportunity, and we hope we can secure funding for this strategic program. Thank you.
Thank you very much. That was a great video. I'll just mention, I mean, there were so many great people that were involved in these projects. Tambozi, she ran the Maimwana, and there are a whole range. Florida was a fantastic community mobilization leader and still advises WCF. And I'll mention Mikey Rosato because he spent 7 years living in Malawi helping to set up Maimwana and all the many really great things that they did, and then later became the director of Women and Children First. But we may come back to that, but I'm going to move on because we've got to stick to time. And I'm going to hand the floor to Hannah Kuper. Now, Hannah is professor at the London School of Hygiene and Tropical Medicine. She's director of the evidence-based unit for disability in low and middle income countries. And it's a great pleasure to welcome her. And I'm so interested to hear what she's been doing in the field of disability because I'm a bit out of touch. So over to you, Hannah.
Thank you so much. Let me just put my slides up. And thank you for inviting me to present today. So I'm going to be talking about the Missing Billion project, which is about using the PLA approach and to see if we can improve access to healthcare for people with disabilities in Uganda. And I just want to acknowledge all of the groups that have supported this work. So from the MRC and Makeri in Uganda to the implementers of AMREF and of course the great partnership from Women and Children First who've been with us throughout this whole journey. And it was funded by UK Aid and NIHR. So what is the issue? Well, in the world, 16% of the world has a disability. So that's 1.3 billion people. And people with disabilities often face lots of different marginalizations and exclusions, inclusive poverty and education and employment. But one of the areas where people are also left behind is in terms of healthcare. So on average, people with disabilities have got worse health and worse access to healthcare. And our recent work shows that this leads to a 2.2-fold higher mortality rate for people with disabilities, and that translates into a 14-year life expectancy gap. And I'm showing here a map of the world, showing where that gap is even bigger, and you'll see that that life expectancy gap for people with disabilities is even bigger in Africa. So this is a really, really big issue. And part of the issue why people with disabilities have got poor health on average and die earlier is because they face barriers in accessing healthcare. And those are additional to the barriers that everybody faces. So there are additional issues with accessibility, with lack of information, with negative attitudes around disability, Financial is really important, both because on average people with disabilities are poorer, but also because they have much higher healthcare costs. For instance, they may need somebody to come with them to a healthcare facility and have a special kind of accessible transport. So that makes everything very expensive. And there might be the lack of services that they may need, such as for rehabilitation and assistive technology. So we've been thinking very much about this issue and how do you improve access to healthcare for people with disabilities in low resource settings. And the available solutions, they're very few, they've not been evidence-based, and they're generally very top-down. And what we were interested in is seeing what we could do that was grassroots, bottom-up, to really address these issues. And part of the solution had to be inclusion. So one of the key slogans of the disability movement is nothing about us without us. So not only were we looking for something that was really participatory, grassroots and so on, but also participatory, that had people with disabilities and their preferences at their centre. So we obviously knew about PLA, but then started to meet with colleagues at UCL and with Women and Children First to see, okay, is this the thing that could help? And can the PLA approach work for people with disabilities, not just around maternal and child health, but people with disabilities of all ages, to identify and tackle locally relevant barriers to improve healthcare access, health and well-being? So in the first year of the project, we started to work on how we could adapt this PLA approach to people with disabilities, and specifically in Uganda, where the project was going to be. So we did lots of qualitative research together with people with disabilities, with healthcare providers, and with people who'd implemented PLA in different settings. We did a literature review about the kinds of interventions that could improve access to healthcare for people with disabilities. And we had a 4-day design workshop, which was led by Women and Children First, to try and see the kinds of ways that we needed to change PLA, including thinking about things like accessibility, focusing on this joint mission, which was about improving health, and how we were going to adapt the meeting design. For instance, could people with disabilities, would we need to have shorter meetings or meetings with a break in the middle? And just like in other PLA approaches, this intervention will also be supported by health system strengthening activities. So separately, we developed a program of healthcare worker training around disability and looking at the auditing and improving the accessibility of health facilities. Because what we didn't want to do is empower people with disabilities to start lobbying for health, and when they arrive at the health system is not able to provide them services. And the groups some of the pilot groups were established, and the name that they came up for themselves is Tusabola, which in the local language means together we can. So what we've done over the last year is we started to pilot test this, because there are lots of questions about whether these approaches can work for people with disabilities who may be very disempowered within the community, and it may never have been involved in these kinds of community groups. So we set up 5 groups, which we wanted to have. We aimed for 20 people, and it ended up being 35 people, which we then capped, and then we uncapped it in some of the groups, and it went up to 45. So there's really high demand, and we found that people came again and again. They were led by people with disabilities. They met every 2 or 3 weeks over 8 months. We had to do it in a slightly accelerated way for the pilot. And we used mixed methods to see whether it was feasible. So we observed groups, we did interviews with people to look at things like acceptability, demand, implementation, and practicality. And what we found is it was. So there was a demand for the groups, they were accessible, that people had the knowledge and confidence to seek healthcare improved. From some of our findings. So we looked at people before and afterwards, and we did already find some significant improvements. And we found that it was a promising approach to be able to improve community health and social support services in Uganda. One of the questions that I had when bringing people together is that, as we said, people with disabilities face lots of different issues. And were they really going to be willing to focus on health, whether that was a priority or would it be other things? And what we found was, yes, this is a really central issue for people with disabilities. Poverty, of course, is as well. But we also know that when people with disabilities become less poor, when they have more money, one of the first expenditures is on health. So the pilot study was very positive. The kinds of barriers identified were the things that we had anticipated. So lack of financial capacity, negative attitudes of healthcare workers, social isolation, difficulty accessing health facilities and health information. And when the groups came together to implement solutions, most of them were around income generating. So each of the groups set up a savings and loan scheme. But in addition, they also had income generating schemes. So that was either brick building or poultry raising. But they also did additional things. So they had campaigns for inclusion in community activities and outreach. There was improving health education through linking with the health systems. And they also, through linking with the health systems, they also advocated for better treatment. And they campaigned about inclusion in community activities more broadly. So where are we now? So the obsession with evidence continues, and we are in the middle of doing a large-scale trial. So we're doing a pragmatic randomized controlled trial in Uganda. So about half of the groups, we've done a big survey. And in 50 clusters, there's the establishment of the Tusabola group. And in the control areas, there is not, but they are still getting the health system strengthening component. We did the survey in last May, and we are going to look at primary outcomes a year from now to see whether this intervention reduced mortality and unplanned hospitalizations as the primary outcomes. But we're also going to look really broadly about whether it improves quality of life, about morbidity, and about healthcare seeking behaviors, and what people talk about affordability, but also the quality of the care. I want to flag that AMREF have been the implementers. This has been one of their first moves. They're very experienced in PLA, but this has been their first move into disability. And one of the really fabulous things is how engaged they've been in disability. And they're starting to think about integrating disability more into others of their programs. So I just want to finish with one of our members who talked about why this is important to him. And he said, we've always been excluded. Now this is the first time we have a group focusing on us. And not just is it the first time that there's a group focusing on people, but for many people, this is the first time they've been involved in a community group at all. So thank you so much for this opportunity to speak and watch this space. And we're hoping that in a year and a half from now, we can report on the outcomes of the trial. Thank you.
Thank you so much, Hannah. And I hope you can hang around because I think there'll be some questions about this. This is such important work. And can I just say, there's a button at the bottom of your screens, everyone watching, called Q&A. If you go on there, just write down any question that you have about anything you've heard about Scale Up, about how things are done, about working with health workers, about disability aspects. Please do write. It's anonymized, or it will be. I won't mention names. And so you can ask any question you like, and we'll try and answer them when we get to the panel. Well, the one thing that struck me about Hannah's work is that this applies completely to disability in the UK. Okay, it's on a different, there's more resources here, but this need for solidarity of sharing and stuff. And we're just going to, our next thing is a quick video from the the NEON group, sorry, that stands for Nurture Early for Optimal Nutrition. And this was done in the UK with Professor Monica Lackenpaul and her colleagues. So we're just going to show a quick video about that work as well. Over to you, Tonya.
The project we're doing at the moment is working together with the Bangladeshi community in Tower Hamlets. However, this model or this approach that we're designing, we would want to be able to adapt it to other communities because all children want to grow up to be healthy.
The advice needs to be tailored to the needs of the community and the culture, bearing that in mind. I would say that the Bangladeshi people in Tower Hamlets are addicted to rice because they see rice as something that has to be in the diet to grow healthy, to actually fill you up. to actually give you the energy and so forth. And somebody said they actually give fried rice for breakfast to their children, to their child, because they don't see anything wrong with it.
Part of the reason that we're doing this project actually is to reach members of the population that might not ordinarily be exposed to any programs. And one thing that really helped our project, I think, was the community support. So we worked with some wonderful facilitators, and they themselves are adult representatives of the Bangladeshi population from Tower Hamlets, and they helped us with every stage of the research.
We find at the later stage in Bangladeshi community more diabetes, more heart disease, more obesity is happening. So the study aimed to identify the main reason for what the feeding style or food habit lead to the disease.
We spoke to mothers, pregnant women, fathers, members of the community in general. We spoke to health professionals a lot, and they all shared this idea of filling the belly. And filling the belly came to mean there was a lot of anxiety around making sure that the baby ate some food. And I think that links to another concept we spoke a lot about, which is the idea that a healthy baby is a chubby baby.
I think it's family, and everybody has advice to give. My mom, my dad.
If you break the norms, cultural norms, and if you break the norms, this child is, you know, you're a bad parent. You're not listening to our advice, and that's why your child's ill.
You'll find that there's actually a lot of knowledge within the family or within the wider community, and we're not reinventing the wheel. What we want to do is make sure that the information and the knowledge is shared between family members and health professionals and anyone really with a role in complementary feeding.
The community have responded really well to the NEON study. They seem all very interesting. At first they couldn't quite understand, you know, if there was a right and wrong, why do they want to know all this? But when I explained, they were like, oh, okay, wow, does our opinion really matter? And if there's no right and wrong, you know, I like to express my views quite openly.
We tried to look at models that we could look at in these resource poor countries and think, how could we use that within the UK, in our setting, in a town or a city here like Tower Hamlets. We've looked at Nepal, we've looked at India, we've looked at Bangladesh, we've taken some of the learning from some of similar interventions, which have been shown to be very successful in those settings, and now we're adapting that and testing that out in Tower Hamlets with the Bangladeshi community.
When I spoke to the people of the community, they're very much interested about the NEON study because they think this is their study, because it's for their children, how they feed their children.
Every single child should be engaging in school activities, should be able to run around, feel that they want to run around, have their enjoy eating food, but be healthy with what they eat. And we want to help them do that. If we leave it too late, then they are already in a position where they don't want to do physical activity, where they don't feel like running around. And so if we start very, very early with these children and give them a good start in life, then hopefully they can have an enjoyable youth and grow up into healthy adults.
I think the NEON study is very important. Definitely come from my sense of my community, because we are always told what to do, what to feed our children, and sometimes it's not the right answers.
After 4 or 5 years, maybe they totally change the Tower Hamlets Bangladeshi community. You can find them, you can say the healthy community in London, the Tower Hamlet.
Thank you very much. That's really, I mean, this whole method is applicable anywhere. This is not about low-income countries or like whatever, or middle income, or everywhere can, and we'll come back to that in the discussion, but because we're running just 3 or 4 minutes behind, so I'm going to go straight to our final presentation, and it's a real pleasure to welcome Elizabeth Ombech from Afya Research Africa, and she's going to talk about their work with sexual and reproductive health. Welcome, Elizabeth, over to you.
Thank you, Anthony. Slides up. Okay, as the slides come up, my name is Elizabeth Ombech. I work with Afya Research Africa. We are an organization based in Kenya, and we work in 3 thematic areas of health. And one of the things we do is we set up medical centers in hard-to-reach and remote areas, and in partnership with groups and county governments. And mostly these groups are women groups. So for this presentation, we'll talk about the PLA methodology that we adapted for adolescent and sexual reproductive health in Homa Bay County, and it was anchored in the medical centers that we've set up in the remote areas. Next. So based on this methodology, in the western part of the country, specifically Homa Bay County, one of the major problems we have there is teenage pregnancies. And according to the latest KDHS report, is that in Homa Bay County, the pregnancy rates were 23%, compared to the national average of 15%. And this is a major problem because the same county has high HIV infections, and men are mostly affected and they have the highest infection. So we provide family planning and SRH activities to this population. I don't know if you can hear me. To this population, and we provided that you can hear me. I think I got hanged a bit.
Yes, we can hear you clearly, Elizabeth.
Oh, thank you. And we realized mostly these services do not adequately reach the adolescent girls and young women. And this is due to barriers and socio-cultural beliefs that are ingrained in these communities, in the rural communities. And mostly they focus around social norms, expectation, and being that they in the rural had to reach, then also financial constraints come in play. We also realized there's limited knowledge on family planning options, contraceptive options, and SRH information. Based on the statistics, we see that these adolescents are actually sexually active and they lack the necessary information and knowledge to make decisions concerning their SRH. So the results is, of course, we get high pregnancies, STIs, HIV infections in this group. Next. So we partnered with Women and Children First to pilot this methodology, being that there are many programs that have been run in this county, specifically by other organizations, being that it has high HIV and high teenage pregnancies, but the numbers are still not going down. So we thought we can pilot this methodology and see what are the actual barriers and proposed solution from the group that is affected. So we piloted this in 10 locations within our clinics that we've set up. And the methodology followed the usual PLA cycle, where the adolescent met once a month, and it was targeted for 13 to 24. We got a high number than anticipated, but then we worked with what we could get. And the adolescent girls used to meet in the facilities, within the facilities that we've set up. And here is where they discussed their barriers, came up with solutions, and implemented them. Next. So from this pilot, the major problems and barriers that were identified by the adolescent girls and young women were the teenage pregnancies, STI and HIV, and child marriage or early marriages. So these were the most prevalent, and one of the major barriers they identified, the 3 major barriers they identified were lack of parental and peer support, lack of knowledge and awareness, and of course, financial constraints to access these services. Next. So after the cycles were done, the groups came up with their solutions, which are locally relevant, and they could implement them themselves. and they identified the solutions that could address the teenage pregnancies to be practicing safe sex, having health outreaches with integrated services, access to information or information dissemination, parental and community engagement, having information to STI, HIV, and also they tackled HPV vaccinations as part of a future preventive approach. So these solutions were actually implemented by the groups. So in some of the groups, they had parental engagement where the adolescents engaged with the parents and addressed the lack of parental support in terms of getting information or understanding the adolescent stage and what they are going through. So that was really key. And also part of the solutions the adolescent implemented was also having community engagements with the young men and adolescent boys, as also they are part of the problem that these adolescents and young women are facing. So these solutions, and actually one of the biggest solutions that were really implemented was information, access or having access to information about HIV, practicing safe sex, and also ensuring that they can access these services at a time that is convenient for them. So those were part of the solutions that were locally available, affordable, and they could implement themselves. Next. So after the cycle, what we've seen from the running the pilot in those 10 locations, we've seen that there's increased access to our health centers. So we have more adolescents and young women coming for more services, coming for screening for STIs. They are not feeling like there's stigma, because some of the solutions, some of the barriers that they were talking about is stigma or judgment from the health workers, but that was addressed. So there's increase in access for services, preventive and also curative for STIs. More of them are getting vaccinated. Their questions about the HPV vaccination were also addressed within these forums. We know the HPV vaccine is now approved for the adolescent group. So some of them had myths and misconceptions about the vaccines, which were addressed within this group. We also seen there's a youth-friendly communication. So the health providers, over the 10 cycles, the adolescent got acquainted with the health providers, and they came up with a code word or a code way of the health providers giving them the exact services that they want without anybody else in the community being aware of what they went for. You know, in that community, everyone knows each other almost. So if an adolescent comes for the facility and probably they want a family planning method, one may go around. If the provider is not friendly, or sometimes they may go away. So those are some of the things they were addressed in youth-friendly communication. After the pilot, we have some groups which have continued with the PLA groups, but in the school-based clubs, where they continue discussions about the SRH issues they are facing. They have peer learning, and they're just trying to sustain or ensure the upcoming adolescent groups also have access to this information. So we've talked about also improved access to contraceptives. And in one example, we had the PLA group adolescent invite the sub-county reproductive health coordinator and requested for a condom dispenser that was placed in a place that is not very open and nobody could see. So they'll just come to the facility at whatever time is convenient for them, and they pick the contraceptive. So that is one of the examples of the improved access. And also there's one where they actually talk directly to the health provider. So those are the major impacts we've seen. And also participating in the group, the adolescents are more self-aware. They have marked improvement in communicating with their parents, expressing their concerns, and also asking their parents questions about adolescents growing up and what is happening. Also talking about relationships and how to handle them. So we handled so many topics, but these were the major places we've seen impact of the groups. Next. Yeah, so that's a summary of our pilot in the 10 sites in Kenya. And we reach an average of about 580 girls across the 10 sites. And I leave you here with Lensa Akinyi. She's one of PLA group member, a young lady. And she talks about how being a member of the group helped her gain knowledge about SRH, and also has been key to ensure that within her community, girls come for the meeting and they're able to access SRH information and the services that they need in a youth-friendly way. So thank you, everyone. I'll stop there.
Elizabeth, thank you so much. This is incredibly important work, and I hope you're going to be able to write this up or publish about it, because you know, I discovered in Africa, even 10, 12 years ago, women were saying, we need more family planning. They want to have a family, of course they do, but they want to control their birth and number of children. And this is incredibly important, not just for sexual and reproductive health, but for climate change as well, because obviously, you know, Africa is now up to 1.3 billion, and it could double if they don't get this under control. So that's very, very important work. I really like your presentation and all. Thanks to all the presenters. We're going to move on to a panel, and I'd like to welcome our three panelists. By the way, if you can, I hope we haven't had a problem with Q&A. If you can write in any questions, then we'll take them in the panel. But we've got three people joining us now from Bangladesh. One of our partners and colleagues, Dr. Abdul Qudus from the Bangladesh Diabetic Association and the Bangladesh University of Health Sciences. He has been director of the perinatal care unit program for some years and worked with another colleague, Kishwa Azad. He's going to talk about some of the work on diabetes and NCDs, really exciting work in Bangladesh. We've got Dr. Naomi Saville from Nepal. She's lived in Nepal for, I think, more than 25 years, and her family's there. And she is an ecologist, but also has worked extensively on women's health and nutrition, and also working with school children and adolescents, which she'll talk about. And finally, Alamnesh, welcome Alamnesh from Ethiopia, from John Snow International, JSI. And I'm going to start with Alamnesh, because there are a number of questions I want to get into. But Alamnesh, first, one question is, what are the best ways to harness the power of PLA for maternal and newborn health, but at scale? And I believe you have been working a lot with training government health workers in Ethiopia, which is trying to take things to scale. Do you want to say a few words about that?
Thank you so much. First of all, I would like to thank the Women and Children First, who has been supporting us in scaling and testing PLA in the context where we are undertaking an implementation research. As you earlier said, the effectiveness of PLA in terms of reducing mortality of mothers and newborn has been well confirmed. So our work was focused on implementation research. How would it be applied in the Ethiopian context? So in Ethiopia, we used to have a strong community health system and different kind of community health engagement strategies. So PLA is another piece or another addition in this sense that we were trying to see how this will be applied in selected pastoral and agrarian settings. So in our work, we have used the government established system. You know, there is a community health system, and at the lower level, currently we have volunteers. They are called village health leaders. They are serving around 500 population or 100, households, roughly. And that's what we chose to embed this PLA system And that it worked very well. And so far, you know, we have been implementing, we have reached to the 6th meeting, and it has been done very well. In the pastoral setting, there is a similar kind of structure, but it's not called the voluntary village health leaders, but it is kind of a similar approach. So what we have seen is, even though we have not yet finished with the meetings, you know, to demonstrate the effectiveness, first thing. And the second thing, since we are doing an implementation research, you know, we are not into showing the effectiveness in terms of reducing, but there are other indicators that we want to see. So what we have seen is like how the male engagement in the process in terms of, you know, improving women decision making is another issue, but the male's engagement in women's and newborn health. So that we have seen good progress, and especially the fidelity, acceptability, you know, adoption is quite high. And we have seen a lot of males have been engaged, and they are very happy to be part of the process. When it comes to the woman's empowerment, you know, since the process by itself allows the woman to make, you know, to identify their problem and find their own solution to the problem, that has a big, you know, addition to their work in terms of empowerment. So that we have seen it very well. And what we have seen, not initially thought, is like even the district health system engagement with the process is quite high. And that has improved a lot in terms of, you know, getting buy-in by the decision maker at the district level, and also allowing the health, some of the community health workers to be part of it, and, you know, being involved in the training, in all these kind of things has been very much that we have seen. So I don't know if I'm coming back again, I can explain more, but these are some of the things.
Thank you, Amnish. That's really, really useful. I remember I sat next to once to Dr. Kasete, who was the Minister of Health in Ethiopia, and he spent half an hour telling me all about women's groups and community health leaders and how proud he was of it. And I was struck that you have 1 per 500 population, which is a good coverage, and that may be partly a secret of scale up in Ethiopia. But just hold your horses for now, because I want to bring in Naomi next. Naomi, one of the issues is about, you know, different health issues. Now, Naomi, I know you did your PhD in bees, and you got into honey as a household resource in the high Himalaya. And then you joined us and led a huge program of work on nutrition, and latterly on new things that we could talk about. Just give me your background on what the value of PLA has been in nutrition in Nepal.
Thanks, Anthony. Am I audible? Everybody can hear me?
Yeah, we can hear you very clearly.
Great. So we did a large-scale cluster randomized controlled trial back in 2014 to 15 called the Low Birth Weight South Asia Trial. And what we did in that study, we were aiming to improve birth weight, which was, there was a very high proportion of children being born low birth weight at the time. And we were aiming to combine PLA together with either cash transfers or transfers of food to pregnant women. So we tested out PLA on its own, PLA with cash, or PLA with the food transfers. And what we found was that giving out, although there was kind of a graded effect. So we had like PLA on its own did seem to increase birth weight, but not significantly. Cash increased it a bit more, and then giving food together with the PLA increased it a bit more again. But what was interesting was that the adding in of the transfers to the intervention, although we saw better increases in dietary diversity with the cash, there was a little bit of a detraction from the kind of social impact of the groups in terms of getting people mobilized and sort of engaged in the kind of learning, because people were quite distracted by coming to the groups for getting their transfers. But across all the arms, we saw an increase in iron and folic acid uptake. We saw higher odds of women getting a better share of animal source foods in the households than the men, than the male household heads, and also an improvement in the nutritional status of the women as per their MUAC. So it was pretty encouraging to see the effect of PLA there. Since then, it's been interesting that in India, there's been two quite large scale-ups where they've combined PLA with agricultural activities. The Upavan trial, which Ekjut was involved in, involved participatory video making, which was quite interesting. And their study showed that when they combined the PLA groups with making videos about nutrition and agricultural groups making videos about nutrition sensitive agriculture, they had better increase in dietary diversity than if they just did an agricultural intervention on its own, or agricultural video making on its own. So the PLA was making an impact. But what we have seen is that it's better for sort of improving diets than nutritional status. It's more challenging to get the nutritional status in terms of BMI or child wasting or stunting is more challenging to reach impact on. I'll stop there, Anthony, because I know you want to ask more questions.
Thank you. I'll come back to you if I can at the end about some of your work with adolescent kids on environmental monitoring, which could move on to PLA with climate. But I want to move to Kudus now. And Kudus, your team did some amazing work on looking at non-communicable diseases. And I just wondered if you'd update us on some of that work with the DMAGIC trial.
Thank you, Anthony, for taking this initiative.
Oh, Kudus, have you frozen?
Hello, can you hear me?
Yeah, I can hear you. That's great. It might be me that froze. Yeah, carry on.
Thank you. Thank you for taking this initiative, organizing this webinar, and thanks to WCF colleagues for making this happen. So after working for around 12 years in MNCH issue using PLA approach through participatory groups and having significant improvement in maternal and neonatal health, we then switched to use PLA approach for the prevention and control of diabetes in rural Bangladesh. It is called DMAGIC trial. It was a three-armed randomized.
Is it me who's frozen?
Trial. It was a three-armed randomized control trial, one with participatory groups, and another was mHealth, and another was control.
We seem to have some frozen screens. Is this me or you? Maybe if Naomi, Alamnesh, and I switch our video off.
Yeah, we can hear Kudus, or I can.
Oh, is it me? Oh, I'll come in.
Yeah. Go ahead, Kudus.
Okay, thank you. So the DMAGIC trial took place between 2015 and 2018, and after the trial we assessed the results, and it was a significant improvement. There was a large reduction in the combined prevalence of type 2 diabetes and intermediate hyperglycemia in PLA groups when we compared to control groups, and the reduction was 21%. And we also followed a cohort of intermediate hyperglycemia for 2 years. And after 2 years, the 2-year cumulative incidence of diabetes in the cohort was significantly lower in the PLA group compared to control group, representing an absolute incidence reduction around 9%. So we could say that PLA is really effective in the prevention and control of diabetes in rural Bangladesh. Then we replicate this study in other upazila of Faridpur district. It's called Alpha Danga, that how the PLA works when it is worked in another upazila. But you know that is called declared trial, and declared trial ran during the COVID-19. So there they stop the meeting because of the government rules and regulations. So we think the attendance in the meeting was not expected level. And when we assess the declared result, it was shown that there is no intervention effect on diabetes prevalence, but the knowledge has improved significantly. But we observed one interesting findings during the declared trial, that we observed an important change in blood pressure with a lower prevalence observed in the fuel intervention cluster compared to control. And these differences in blood pressure translate to reduction in mean arterial pressure, which is an important marker of cardiovascular disease. So if we summarize the declare and DMAGIC trial, we could say that participatory group through PL approach is equally important for diabetes and hypertension prevalence reduction. And we know that due to lack of knowledge in the rural areas, so as well as diabetes, as well as hypertension is one of the important causes of health concern, including death, disability, and stroke, and other things. Very recently, we have started a new project in Faridpur city, targeting the NCD risks in urban area along with another partner in Kathmandu. So what we are assessing, that we have worked in rural areas using PLF for NCD prevention and control. Now we are moving to urban area using the PLA approach, but not the same methodology for using the participatory group. Rather, we are using co-production group and NCD action group. Through co-production group, we will target young scientists, that means the citizens of the community will be involved in the scientific process along with the professional scientists. And we are also switching not only from hypertension, diabetes, we are also targeting other NCDs like kidney failure and COPD and also some sorts of cancer. Even because we know that physical activity and diet modification definitely have some impact on cancer prevention. And if you could raise the awareness among the city people, then they could screen for common cancer prevention, for instance, breast cancer, colon cancer, and prostate cancer. So this study has started from August, and it is a 3.5-year study. And we believe that at the end of the study, we could be able to show PLA impact on other NCDs in urban area as well as rural area. Thank you.
Fantastic. Can you hear me?
Yeah.
You can. Sorry, we've had a little technical problem at this end because we're a de-developing nation. Just a quick question. There's a question from Fiona Doobie, who has a fantastic career in this and has worked in Bangladesh. She says, did you work on the women's groups with the other financial organizations? Because she was worried that without finance, the women would not have the power. Did you do any of that with BRAC or with Eunice's group?
Thank you, Anthony. As we have not yet started, but one thing I forget to mention that. So one thing I forget to mention that when we ends the groups, most of the groups stops meeting again. Considering that thing in mind, so what we have started in one small area as a pilot in Faridpur district, that we are using health screening alongside the participatory groups. So we are calling them the NCD mobilizers. So they are conducting participatory groups, and after 3 to 4 meetings, they are asking for health screening. And we have conducted a contingency survey in the community, that the community are willing to pay for the health screening services. And it was remarkable. In last month, we have just assessed the performance, and the NCD mobilizer who is offering the health screening services along with the participatory group, and they could earn around 60% of their salary from the community. So it is so interesting that if we could earn 60 to 70% money from the community after conducting the participatory group through health screening services, then other community-based organization, philanthropist, or local government representative could carry out these activities, including 30% cost. So this could be one business model that we could run the participatory groups as well as earn money through health screening from the community. And this could be a sustainable model beyond the government, and we are looking for other funds so that we could scale it up to more areas in Faridpur and other districts. At the same time, we are also working with community clinic project could take some of our PLA in their existing groups, and we are also discussing with the BRAC and other partner organizations who have community work, so that we could combine the PLA and health screening services so that we could generate significant amount of money from the community, and that could be scaled up along with other partners. And some NGOs in the rural area have significant money they have earned from microcredit, and they have also showed interest, and we could work with them so that they could run the participatory group as well as health screening services through income generation from the community. And I think that could be a good model beyond the government approval and government taking up the PLA. Thank you.
Thanks, Kudus. What really annoyed me was that when you published that amazing paper showing that you could reduce the prevalence of diabetes and pre-diabetes by 60%. It was published in the Lancet and very few people paid any attention to it. And then a year later, they release Ozempic and Wegovy, and everyone's making billions of dollars. And we're more effective groups, and they're more sustainable. I should be a billionaire by now. It's ridiculous. But anyway, thank you, Kudus. That's great. There's a question from Hannah Kuper, and she's saying a question for Nirmala. What's the secret of success for the amazing scale up of PLA, and how it would apply also to in India? Because there was another question that said, how do we do it better in high income countries? Nirmala, I don't know if you're still with us or whether anyone else wants to comment on that. Well, if no one else does, I will. There's a lot of interest in the UK right now about social prescribing, about the fact that we need much more community engagement in order to tackle many of the problems of loneliness, obesity, non-communicable diseases. And we've got a kind of rudimentary system with GPs of social prescribers, but it hasn't really been properly evaluated at scale. And I hope the new minister will take an interest, because he said he wants to reduce the root causes of many of these problems. But I think that is a big challenge for the future. And I think there are differences, but there are not that many differences. And as Hannah Arendt once said, she said, the power is always with a group, and once you go back to the individual, you lose your power. So being in small groups can be extremely, not just the solidarity, but it gives you the power to tackle things. Any other questions? Right, let's take, this is from Taraku Kafawifu, to any of the panel group, what are the mechanisms you use better to ensure the sustainability? Yeah, and this was an earlier question, I think, from about Uganda, how are you going to maintain sustainability of these programs with WCF gone, or if any of you lose your funding? Anyone want to comment on that? Naomi, maybe.
Sorry, Anthony, can you ask the question again? You just cut out there.
Oh, sorry. It's the lousy technology at this end. You know what it's like. Yeah, it was basically about sustainability. And, if you pull the plug on the finance, or you pull the plug, is there any inbuilt sustainability once you get these programs running?
Yeah, I mean, it's always the challenge that we've observed here, is that it's hard to keep groups going. We did go back to groups in Makwanpor, as you said, and some of them were still carrying on. I think Nirmala is probably better placed to answer this question than me, because they have managed to scale it up and get the Ashas doing it at a very large scale through the government system. I think in Nepal we've had problems getting the government to take up PLA as an approach. Going through community volunteers who are already incentivized by the government seems to me the most sustainable way forward. But to get it at a really large scale without dilution is always a challenge. And I feel like Nirmala had her hand up. If she could possibly give us a quick answer. She was here. I don't know if you're still here, Nirmala, but I think you are much better placed to answer this question than me. I don't know. Is she still there?
Well, if we can't hear her,
Her
if she
hand
comes
up.
in, that's great. But if
She
not,
had her hand up.
can I? Has she got a hand up?
She had, yeah.
But we can't see her at this end. Can I just ask? We got to finish soon. And I just want to ask one other thing. Oh, Nirmala, you're muted. Do speak.
Yeah, thank you, Hannah, for this question. Yeah, I think to answer to Hannah's question about how we, we can harness the PLA, for example. What we have learned is through research, if we are able to have a very good evidence-based something to give to the government, and maybe every now and then talking to the government officials and talking about the improvements and how communities are getting engaged. So every time we use MIS to see the attendance, for example, how women are participating in these meetings. So there is the buy-in from the government, and that actually helps us in scaling up. To answer to Naomi's question, sustainability is something that, because the way we engage with the government and government system, so everything is planned by them. So we are just providing technical assistance to the government to get this going, and influencing them in a way that this gets budgeted in their annual budget. So that is also one thing that has ensured sustainability of the entire project, because once the frontline workers are trained to do this, even if we as NGO partner withdraw, the learning remains with them, and this can continue to happen. It doesn't have to be in a women's group, but it can be even during home visits or something. The information is already there with them, and they can use it as and when they require. So that's the way sustainability for us has looked like. And one other interesting observation is, in our first trial, the membership in the groups used to be roughly between 18 and 19 average attendance in a group, which is actually right now, when the ASHAs are conducting these meetings, we noticed an average attendance of 26 or 27 women in the meetings, which actually shows if the meetings are interesting and people are willing to come and sit through the meeting. And we've also reduced the other time. Earlier it used to be, say, 1.5 to 2 hours. Now we are particularly paying attention to reducing the time, so that people do not spend too much time at these meetings, but the content is quite not only heavy, but relevant to them, to their needs. And that's the way I think sustainability happens, and people do keep coming again and again for the meetings. So making the meetings interesting and something new in every meeting is the way I think we look at it.
Thanks, Nirmala. Just to, I'm just going to, before I hand over to Rachel, a couple of points. Michelle Hayes in the chat made the point that the NEON studies in the UK are continuing with 2 new trials. So we need to watch that out for that, as well as all the growing evidence around social prescribing. Can I just make a final point? Then I'm going to hand to Rachel, and that is, the biggest threat to all of us is climate change. It is the biggest global threat of the 21st century. And people in the poorest countries are going to be the most affected first, but all regions of the world are being affected now. And I think PLA has a critical role to play in this. And I also mention that because climate change is where, with all the aid cuts, USAID has disappeared, ODA in Britain has been cut. But climate money is increasing, and I think we should all be thinking about ways in which because this impacts upon mothers, on children, the disabled, nutrition, everything. So that was my final departing point, and I hope we can raise more money from that. But I'm going to hand over finally, because we are a bit over time, to Rachel Cullen, who has been our fantastic chair at Women and Children First. And she's going to just sum up some of the points that's come. A huge thank you, by the way, to everyone, because the contributions from everybody have been fantastic. Rachel.
Thank you. There's something very technical going on here where we move the laptop around. I'm not going to sum up actually, because I think we're a bit short on time.
Yeah.
There's just so much that's been said today that I know I won't do it any justice. But as Ashley said, I've had the privilege of chairing Women and Children First for the last 2.5 years. I want to say thank you to everyone who's been involved today. Thank you, Anthony, for such great chairing, and to our fantastic presenters and panelists who've really shared their insights of different parts of the PLA and Women and Children First journey over the last 25 years. Also a quick shout out to Tonye from Muno Events for coordinating all this so efficiently. I think you all know we made the really sad decision to close Women and Children First a few months ago, and we're actually in our final week. You can't see, but around me are actually the really wonderful Women and Children First team. That's Joe and Annie and Mark and Misha and Lisa and our CEO Beth. And while we're really sad to be closing, we are immensely, immensely proud of the legacy of this organisation. As you've seen today, PLA has been constantly evolving over the last 25 years, but it's not the preserve of Women and Children First. There are so many organisations and academics, activists all out there involved in this journey. And a quick plug that our website is still going to be available, and you can find a directory of all those people if you want to connect with each other. I hope you still do on that website, because that journey is going to continue even without us. So we're really, really sad to say goodbye, but we are super excited about how PLA will continue. So it just leaves me to say thank you to all of you. Thank you for attending this webinar, and thank you for the last 25 years for all your support and for all of your partnership. So thank you and goodbye for now.